Good afternoon, everyone. Uh, Welcome. Um, it's now 4:30. Can we can we go ahead and start? Or do you expect much more person? I'm not hearing a response, so I take that as we will go ahead and start. Um, um, so afternoon again. Today we're going to look at a little bit on investigation of infectious disease outbreak. It's meant to be an interactive um, session, and so we'll go into breakout groups. Maybe depend if it's just four persons on, we may just do one group and work as a big group. Well, not really a big group, but as one group. Um, and so what we will do is for the first few minutes, define what outbreaks and the purpose of outbreak investigation, the steps that are involved, and what we should include in risk communication. Then we'll do some case studies, which usually is in the breakout group, but we may not have to go into smaller groups. So outbreaks or an epidemic is the occurrence of a health-related event clearly in excess of what is expected. It's, Outbreak and epidemic are used, it's the same thing really. Um, so if it exceeds what is normal, so some conditions, for example, if there's one measles case in Jamaica, it is considered an outbreak. Anywhere in the world, a smallpox, one case would be considered an outbreak. So the outbreak duration depends what is causing the outbreak, and it can last for a few hours, a few weeks, or several years, as we have seen in COVID-19. So the purpose of outbreak uh, um, investigation is to really to identify the responsible agent and find a source of infection by studying how things occur, as well as determine the specific attack rates. And I'm sure you have done those calculations already and formulate some recommendation to prevent further transmission. So there are what typically we hear about 10 steps for outbreak investigation, and some say for 13 steps. Pretty much is the same. So prepare for field work, establish the existence of an outbreak, and then we verify the diagnosis, go about verify the diagnosis, define cases and identify them, describe and orient the data in terms of time, place, or person. And then we develop some hypothesis as to why this is occurring. And we need to test that hypothesis, evaluate it, refine the hypothesis if necessary, and carry out additional study. And then we implement control and prevention measures, communicate findings. And these steps are written 1 to 10 or 1 to 13, but the expectation is that these activities will go hand in hand because even before we reach on the scene and we hear about some of the symptoms and so on, we might implement control and prevention measures. So while we're on the way, he said, okay, do this, do that. Because, this is the likely cause of it, just by what we hear. So we go into the steps in a little bit more detail and some recommendations. So prepare for the field work. Based on the first call, you need to think about what could this be and read up before you go. Decide what you need to take, your collection sheets, your sampling. These days you can probably do up your questionnaire on a electronic device and collect that. And then we need to make some administrative and personal arrangement, such as how we're going to handle samples. Because if, and say a foodborne outbreak, we have to have custody of the sample from where we purchase or where the incident happened to when the results come back. Because, if it's incriminating, then nobody wants that on their watch. We need to talk, we need to sort out our home situation, make arrangement, pick up children, because you don't know what the day will bring, because outbreaks notoriously occur Friday afternoon when we're looking to go home early, so we have to make those arrangements. So it's really to prepare. Is it really an outbreak, or is it's just a chance thing? So we need to establish whether there really is in fact an outbreak. We need to identify the specific nature of the disease, define and identify cases. So we always talk about this case definition. It's a standard set of criteria for deciding whether in this investigation a person should be classified as having the disease or the condition that we are looking into. And we may have confirmed, probable, and suspected. And we need to define what each mean. And so we can categorize what we are seeing. And this we may be able to do based on how much information we got before going out. And we go out with a working diagnosis. And even our data collection sheet will make sure we pick up all these symptoms and signs. So in any investigation, we need to describe and orient the data in terms of time, place, and person, right? We develop a hypothesis and we evaluate that hypothesis. What we often, so we tend to be very descriptive in our outbreak investigation, but we really should look at how we can do more analytical outbreak investigation and testing of our hypotheses. Most outbreaks, we probably would be able to do case control study. Those with disease, those with not disease, and what the exposures are, possibly. And then we refine the hypothesis, and if necessary, carry out additional studies. And we implement a control and prevention measure. Um, and as I said, it may come at the very beginning and communicate our findings, do our report. So outbreak investigation, the first thing we need to do a report, even if this is that interim report, we need to do it. So that takes us through the steps. And there are things that we should really do. Decide on who is to do the investigation, the type of investigation, who is the most experienced on the team. Should that be the team leader? But you need a team leader. And the team needs to be briefed before and what's the risk communication strategy? How do we communicate in what we're doing? Because sure enough, if a Ministry of Health team comes out there and doing an investigation, it's going to be an issue. And we do a debriefing when we return. Our reports and follow-up actions are to be done. So what should our approach be to risk communication? The three things that have influenced how we do risk communication is that over time, experts and authorities are less trusted. So people don't really trust them, the Ministry of Health anymore because we're hiding stuff. And there's so many persons that you can tell you things. The way public health advice has really shifted over time with all the online sources and social network, and everybody is a public health specialist. So, and everything is 1 minute this happened, next minute it's on social media. So we are turning out news all the time. And all of us have had the experience of what is happening and who's involved. So when we did a study in 2020, and asking where do person get in information from? 1 second. Sorry about that. So the traditional media is still where most persons get their information from. And this was for coronavirus. Social media, friends and family, international media, and Government of Jamaica press conferences and GOJ social media are some of the top places that persons would have gotten information from. But the sources are different for different age group. So the official sources, so persons in their 30s and 40s and 50s and 60s, the older person, are official sources. Traditional media, as we would expect, the older persons tend to do the traditional media, while the younger persons tend to do other sources. And we remember all the rumors that were there. And sometimes things in our paper or news items are picked up internationally. So the news in the UK picked up this deadly Ebola-like plague in Jamaica. And what they were talking and court, quoting the Minister of Health and Wellness of Jamaica. But we're talking about dengue, and within the article, the Gleaner reporter had described dengue as an Ebola-like disease called dengue hemorrhagic fever. And so this went throughout. So we have to think about the communication and the risk communication. So the key principles of risk communication are those of trust and transparency. Our goal is that our concerned public heed our requests. We also need to release information even when that information is complete or not fully confirmed. So it will be at this time we are able to say we have this. What we cannot say is X, Y, Z. All right. So that is the more setting the stage for the application and this case study. Just checking in. So we have most persons that I figure are on now. So we'll do two groups, Mr. Suarez, breakout group. But let me go. So there are about 20 or 19, so 10 in a group. And we'll do two group. So the case study is on tuberculosis. So we're going to do one chronic disease and one chronic infectious disease and one more acute infectious disease. So TB, our case study, the public health nurse assigned to 5 Circles Health Center in KSA reports to the medical officer health that there were 5 cases of tuberculosis reported since the start of the year. A 36-year-old fireman diagnosed in January, a 15-year-old male in March, a 17-year-old male nephew of the fireman diagnosed in July, a 16-year-old male friend of C, and in August, a 16-year-old female girlfriend of D diagnosed in November after contact investigation of E. Some key points that what are some of the key points you need to consider about TB? Is there an outbreak of tuberculosis in 5 Circles Garden? What further information would you need to know about these cases in order to plan? How would you go about getting this information? And what strategies would you employ in this situation? I'll leave this on. And then, Mr. Suarez, could we do the breakout groups? Any question before? No questions?
Is it possible to see the outline for the steps again, please?
Sure.
Thank you. Thank you.
Yeah.
Just a good afternoon, Doc. Good afternoon, everyone.
Okay.
is it that we're to is in terms of presenting, I guess I gather when we're finished, we'll be presenting as a group of sorts.
Yes, also. So it really does, yeah.
Okay, so we should use the time to create a PowerPoint presentation of
Oh,
sorts.
no, no, it's just a discussion.
This okay, understood. Thank you.
Just a discussion because we want to go through it as quickly as possible to get through just a feel of how we would investigate because it's just 2 hours, eh? And we want to finish on time and would have gone through this. So
Okay,
um,
thank you very much.
Mr. Suarez?
Yes, ma'am.
Yes, we can go into breakout groups. We just 2 groups.
How many groups? Two?
2, yeah. So we are back together. So we'll take group 1, key points that you need to consider about TB.
Not sure how we knew who was group one.
Well,
Oh,
we were group
Oh,
one.
okay, cool. Thanks.
So I was a scribe, so we wanted to start with the case definition of TB, understanding how the disease is transmitted, its infectivity, the time taken between exposure to development of symptoms, and the period in which the client might be infected, might be infectious,
mhm,
mm, and transmissible, but not necessarily have symptoms of the disease.
mhm,
And we also need to get pre-existing data and compare it to what exists, essentially to have an understanding of what the endemic levels of tuberculosis are within the area to actually determine if it is an outbreak, if it goes over the normal numbers or normal levels within the region. And
mhm,
then we started to look further into like the other questions that we need to know, such as the people, the relationships that they have with each other, the circle of interaction. There were established relationships. 4 out of the 5 cases were all linked to each other at some point, right? We also wanted to come back and look at disease surveillance, right? So the testing, the management, at what point do these people get diagnosed? Um, and then we also took into consideration possible vaccination status, underlying conditions, what made these people susceptible to the infections, um, the medical history of same, and a colleague of mine raised the point of compliance with treatment as when we were looking closer at, the timelines between the diagnoses. They were
mhm,
pretty much in keeping with the standard 2 to 12 weeks for initial infection. However, it can take months or years for active disease to develop. Looking at a timeline from when the initial individual A got infected and got diagnosed rather in January, then subsequent to that, contact C, who lived with him, was diagnosed in July. The friend of C was diagnosed shortly thereafter the girlfriend of CE be diagnosed subsequent to that. So we need to properly understand, the relationships between these individuals, mm, and
Okay.
what exists. I'll go ahead and have one of my colleagues talk about how we
Yeah.
go about getting the information and the strategies we can employ
Okay,
to this
so
situation.
okay, probably we ask group two if they have anything to add.
Well, they've said pretty much everything we'd say, but in terms of addition,
Yeah.
in continuation from the note about the timelines,
Mhm.
drug resistance, in terms of the characteristics, because if it had been treated and he does, still is transmitting, then is it that treatment was effective? Are we dealing with an issue of the patient having perhaps resistance to rifampicin, for example? Is that TB resistant, pulmonary versus extrapulmonary TB? I think he mentioned HIV status as well. I think so. Um, those were the major additions I'd say came out. And additional exposures. I wanted to add because in terms of school, the fireman being a fireman, exposures at the fire station, school because minors, the 16-year-old, etc. There are also minors there, so those exposure conditions would have to be considered as well in the context of what we covered so far in terms of disease characteristics, whether it's an outbreak, and further information we'd need at the case level and then in terms of exposure and transmission.
Okay. I think group one, you were going to add something on
Yeah, they were
for
gonna say
the
something.
further information.
What I would want to add is vaccine status of the individuals that got the disease. Were they
Okay.
vaccinated before, especially the younger ones?
All right.
I think
Okay.
Akeem kind of addressed some of the stuff well that it is that we would have wanted to talk about too.
Right. Okay.
And I guess in the same conversation of like the spatial relationship between everyone, especially the
Right.
younger ones, that would aid in your strategies regarding obtaining
Mhm.
information about who else might be infected, but maybe not necessarily flagged by the MOH, the medical officer, sorry.
Okay. All right. So thanks. I think we we did pretty well. Just the
Oh, we had to. Oh, okay.
okay. Go ahead, please.
No, well, in terms of the other two, I
Mhm.
think we covered, well, group one pretty much covered the first part. I thought they were gonna go into the other this what
Right.
strategies would you how
We
would you
need to
go
add.
about getting the information and then strategies you'd employ in this situation.
Sure. Yeah.
Right, but in terms of going about um getting the information, they did touch on that the baseline,
Mhm.
incidence of tuberculosis in KSA 5 circles.
Right.
You want to know about previous TB cases in the area.
Mhm.
Yeah, and of course, in the same context of HIV, if there are any vulnerable groups that you want to consider, in terms of how would you go about getting this information, of course, you'd want to explore your sources, review clinic records, if possible, check with local personnel about that. You want to do your interviews, interview the cases being considered here. Visits, you want to be visiting and looking around the household, the workplace, that's the fireplace, the
Mhm.
schools for the minors, for example. Tracing, contact tracing as well. Um, uh, yes, and then strategies to employ in this situation.
Mhm.
Um, you'd want to, of course, isolate your infectious cases appropriately, as is required. You want to screen all close contacts, that is the schoolmates for the minors, the other fire station staff, the households, because they saw the nephew and so on being included. So the households, the fire station staff, the schools, any other contacts that may come up, and provide, I'd say prophylaxis, where we are required for certain cases. And then, of course, that's, then there's the active component. You want to actively go out, in those exposed areas and screen. I think that's as far as we got.
Okay.
And
So,
also
okay.
in terms of
Yes.
strategies, you
Yeah.
want to in providing all of that, also information in what persons are to look for. So coming out of your case definition, you'll be advising persons what to look for, what to report, and how to conduct themselves. So hygienic measures and so on.
Okay. All right. Good. So just a few things. With the matter of the vaccine, the BCG is for miliary TB, so it's really protective at a young age to prevent that TB. It has very little effect, if any, on older persons. So while it's a control measure generally for vaccines as to control infectious disease, but where it's of biggest use is in the infants to protect against miliary TB. So the key point, and I think that this would have come out already, that TB is transmitted through the air, cough, sneezing, singing, laughing. And they may become infected. The risk of transmission is affected by the infectiousness of person with TB, the duration of the exposure, and the environment. If you are a close contact, and look, these are close contact, the risk of infection is about 70%. Close contact is share a house or a room with somebody. And only about 30% will get infection. Of that, about 5 to 10% will have early progression. That's within 2 years. So you may be get an infection of the bacteria, but you don't go on to get the disease. The disease may come later down. And for TB, early progression is less than 2 years, but most of us contain TB. And it's later progression, reactivation. And most people continue to contain. However, for persons with HIV and persons with, say, diabetes, their progression, lifetime progression is much, much more. All right. So while like HIV, their progression maybe 5% each year. So I mean, it's a different thing. We asked about what is the usual numbers in so this is some real cases. So in 15 years, the 5 Circle Gardens had 58 cases the year before these 5 cases. So is it an outbreak? Just to say, our case detection rate around that time was about 70, 75, 80%. So
Just to be clear, sorry, Dr. Whitaker, you said the prior year there was a record of 58 cases.
No, so in a 15-year period, there were 58 cases.
Oh, in 15 years. Okay.
In 15 years, there were 58 cases.
Okay, and then 5 cases in 1 year, basically.
Yes, yes.
It would seem like it is an outbreak.
It's a little bit above. Yeah. Because that would have been at a rate of about 3.8 if you want
Yeah,
to
so it would be an outbreak.
Yeah, I would agree with Akeem because it's higher than what you would expect. The
So,
3.8, roughly 4.
right. So,
And maybe how the 58 were like over, yes, it's over 15 years, but like maybe it's like, okay, we see 5 in I don't know how to say it, but maybe like you have a few years when you have no cases, and then another year you might have 5 or 2 or 10, and then it goes silent again. So maybe the pattern or the trend would be
Could you go
important
back to the
about 15
slide where
years.
you have the case pickup rate, please? Not that one. The graph, please.
the graph. Oh,
Right, the case detection rate. So yeah, even then for those years, the TB detection rate was below what the global target would have been. So if it is that you want to err on the side of caution, then it could imply that there are even more cases that you're not taking account for.
sure. But yeah, so
Explain that for me, Danny.
then it goes the other way for that. So if you're not picking it up in the earlier years, but you're picking it up now, then maybe it's not an outbreak because you weren't detecting. But now, in this year, you are picking up more than you used to.
Oh,
So
so your surveillance techniques
those
are
are some of the things that you would have to consider. But I like I prefer the idea of earn on caution, but there are methods for calculating what is expected and what is not. So you looked at it and said this is the average, but another person was talking about the distribution. Some year it might be the 5, and some years 10, and then 0 and whatever. So the spread, so the standard deviation is important to say, is this really normal or not? So it's the usual that we would, is mean plus 2 standard deviation above the mean for any year, right? So maybe it is, maybe it's not. So we'd have to get a more objective is to look year by year, and then for the 15 years, do the mean plus 2 standard deviation to say whether it's an outbreak or not. But for sure, there is a cluster. So, and there are other things to consider. I'm not going to break out again because when we break out, we spend more time, but you can see. So some say maybe or some not an outbreak. So these are just some of the things that uh, is, and this, in sense, it is just a small area of Five Circle Gardens because it's a bigger area. And so if the cluster is just right there, could be an outbreak, you know? So things to probably consider for further identifying source, finding contacts. Not because one person was diagnosed first means that they are the index case. and doing our contact tracing, there could also be consideration. So the biggest way of finding cases is to do case investigation. Who are the close contact for TB? Because that's how it spread. Yes, you can get TB from not so close contact, but the risk is much, much lower. So your energy should be those in close contact. And but also we could consider community surveillance and health facility surveillance. So health facility surveillance may look like anybody who comes in with a cough, a productive cough, their sputum is taken and checked. That irrespective of them having a diagnosis. And community surveillance is that you basically go house to house and do some checks on person. Do you have a cough? How long you have the cough for? And can do other measurements. So this is the thing. Because we went into Five Gardens, this media called their MP and the ministries in the community so often. They said 300 person know. They hear that you're in there for TB, and 300 person know want to be tested for TB. What is your response? Group 2, anybody can make a stab at it. No?
Good afternoon.
I'm thinking that,
Oh,
go ahead.
well, looking at the result, one is that the communication with the community should have been better. So the mere fact you recognize that you need to be in the community and you will have to interact with persons, it would have been good to have a sort of community meeting or have the CHAs have contact with when they go out, inform persons that this is what is happening, this is why we're doing this. And so people are aware rather than have speculation. And then there is also, well, for me, who is this? And then we have to
300
decide
person
early
want to
whether or
be
not the media
tested.
should have been informed. Because
What
if
would you
we
inform
inform the
them
media
on?
and the information was out there, then it would also have prevented some of the anxiety that people are having. But in this case, we need to explain what the risks are, who are the people who are actually susceptible, how would you likely get TB? This is where you need to give as much information as possible to the public about the illness and also how they identify symptoms and how they prevent. And in terms of the 300 persons wanting to be tested, then you would want to engage each person, ask the questions that are required, and then individualized, because you don't want to then tell people that, oh, none of you need to be tested, and then it turns out that their person they were positive. So I would suggest that we engage each person after giving the broader conversation, that the persons who want to be tested, we engage them, find out if they have any symptoms, if they've been in contact, and then test accordingly.
I agree. I just add that, I don't know if you said it, but I think you mentioned community engagement, and it just threw me back to AT2. But yes, engage the community first, not the media, because they'd have already jumped on and they might have been a little sensationalist, and that may have fear mongered more than health mongered. So I'd say instead of engage media and posters, you do a town hall meet. I think you mentioned engaging the individuals. So yes, town hall meeting of sorts. Say engage that community as a group, and educate them about the disease and educate them that, sure, 300 persons want to be tested. You don't want to dismiss them. I might be straying away from epidemiology history a little bit here, but the first thing, you don't want to first dismiss the community's concern, because that often backfires. So you want to reassure them that, yes, your concerns are valid. Yes, it's okay to be concerned. However, this is the type of disease it is. This is how it's transmitted. These are the persons who are most at risk. So while we are willing to test, we'll be focusing our testing capacity and our follow-up capacity and our resources on certain persons first, based on, their exposures, their contact history, etc. Yeah.
Okay.
That's what I wanted to zero in on, what Dr. Nicole was saying, and to do persons individually. I wanted to make the point that maybe you were not able to get to the 300 persons in a timely manner before persons get frustrated, and so first you have that, as she pointed out, the wider information given, and then you could take it down a tier where these 300 persons, as to what Akeem came on with now, given the list and saying, if you answer yes to, say, 3 or more of these questions, then yes, you need to be tested, as opposed to if not. So all this coming based on your case definition and so on, and you'd be able to then get persons. But I wouldn't suggest a town hall, given the fact that it is spread by close contact. So we still have to use our other means of communicating to.
But close contact, I should say, means sharing the same room as
Sharing the
kids. So
same
open
room.
air town hall wouldn't
Well,
be a risky
right.
situation.
Or
But
on the street.
I understand that. And
At the
as you can
square.
see, there's probably not any right or wrong answer, but we have to be for sure sensitive to what the general public would need. And risk communication is an important part of epidemiology, because it can make or break your investigation. And
as Nicole said, you don't want person to become disinterested, so you really
right,
want to get to them and answer their
right. And you
question.
don't want them panicking too.
Mm-hmm.
And because that can happen as well, that person get panic, and a lot of people get involved in. But I like the idea of the individualizing thing and meeting persons where they're at, and explaining to them, because most of these persons are unlikely to need testing. The fact is, the best screening, if you have this situation, is a chest X-ray, which picks up TB probably a month before the person have a cough, and it's a better screening. But these are some of the things. So the sort of Mantoux testing followed by chest X-ray is picking up personal data, and they would have to have, you would then have symptoms. So I think that is good. And I can't talk. Oh, sorry about that. So I think the responses were good. It's basically to think it through, engage persons who know the community and can reach persons. So if it's your contact investigators, your a public health nurse who knows the community and so on, to be involved in this. And then share the information up and down the ladder, so that persons are aware. And we need to educate each other. So all healthcare workers need to know what TB is or whatever we are dealing with and how it's prevented and controlled. Because sometimes the healthcare worker needs to help the community along to get in there quicker. So the next case study is foodborne disease. So these are some cases that we have had to investigate. Well, I worked in KSA for a long time, so these are on December 7th, we received a call from an employee of Stages Crossroad, a multinational furniture store, who stated that she and her coworkers became ill with diarrhea after having Christmas sample of products made with cow's ingredient. We'll ask the first set of questions in the big group, and then the second set of questions will break out. What group of diseases you consider on getting this call? And what information important now in your search? So you get the call, and this person is sick with diarrhea. Is there anything? No. So, okay, since what other information you would want to help you along the way?
I'm thinking that oh, sorry.
Go ahead, please.
I'm thinking the diarrheal illnesses in general. There's a foodborne intoxication. Well, foodborne illness versus foodborne infection.
Mm-hmm.
I know I don't know if somebody can call a friend, but I'm trying to put on environmental health here.
Okay.
I was thinking like salmonellosis and those things.
Okay.
Yeah.
Yeah.
I
Right.
posted it
versus
in the chat.
Okay.
Yeah,
Shigella,
right.
some E. coli toxin, dysentery, things that depending on
Right.
what type of diarrhea they're
Right.
having, bloody
Right. Some
diarrhea
are toxic,
versus,
right.
Okay.
Right. And then the time,
Mm-hmm. The incubation period, yes.
right, the
right.
incubation
And when did
period.
they eat the food,
Mm-hmm.
and how long after eating the food did symptoms began? Because I know with infectious organisms, it takes a couple of days, but with a toxin, it can happen in hours.
Well, toxins is very short, in less than hours too. But yeah, that's general. But there are some infections, and you mentioned them, like salmonellosis, which may be shorter. Could be days, but it could be hours.
Okay.
Yeah, so yeah, I mean, you're all on the right track. And then I heard other things coming out. So the time frame, which is the incubation period, also will narrow your search. So if everybody's coming down with it in 8 hours vis-a-vis 24, 48, 72 hours, you know what your search would be like. Other things like probably a fever will be important as well.
I just wanted to add that it was kind of vague. Well, it said which co-product. Oh, sorry, it skipped.
Oh, because I didn't want to give name of the product.
Right, because there's always milk, the cream-based stuff,
Right.
pastry, ice, and I guess that
So
would
it's a
also
it's a
under.
milk-based product.
Okay, understood. Thank you.
So which is what we so there are like this, I don't even know if this is there, but there's this compendium that gives I should check it out, gives the different type of foodborne illnesses and give you the incubation period, what are the sort of symptoms, um, and the duration of illness. So if everybody have diarrhea and they're better, or are they having fever and going to the hospital, okay. So this is where we go in for, we close the room at 6. So we'll look at what would be our next step, the timing, where would you get the information. So just give the columns that you would need for your data collection or the variables and risk communication. How would you approach the communication in this? Indicate how you would analyze your data and what would your report look like. So we have 15 minutes till 6 o'clock. So Mr. Soares, I don't know if you can
Wait, 1 second, Doc. Could you just please go back to the other, so I can see the
sorry.
next one? This slide
Um,
with the questions.
hmm.
Okay, and there's another one. Okay, thank you.
Thank you. So to be we'll do the breakout rooms. So I guess I can do it, recreate.
It's just in a few days.
Welcome back, everyone. Group 2, you can take all that on this page, and then group 1 will add anything else. Hopefully, somebody was taking notes. Group 2?
Two. Hi.
Hi.
What was your name? Is it Nicole from group 2? Do you want to be our speaker? I'll present the
You'd
notes.
have to share you're going to share the
Yeah.
notes?
But you could be our speaker.
Okay, no problem. All right, good afternoon, everyone. So we took it from the point of view of trying to cover the 10 steps in the the outbreak investigation. So we started with actually trying to confirm whether or not an outbreak exists. And for this, we thought it was necessary to, given the context, we would look at past data, but it was important to look specifically at the exposure and the persons who were exposed, as well as the symptoms and signs that they developed. And when we looked at symptoms, we wanted to also specifically look at not only the symptoms they developed, but the time that it took for them to develop those symptoms, because that would be important in terms of determining which likely causative agent it was. We thought it was important at that point to have information on the characteristics of the persons. So knowing what their sex and age was. Also wanted to also confirm what the possible exposures were. If it was something specific, they said that they had samples. So we wanted to know which samples they would have been exposed to. We wanted to also look at everyone to see how many people were exposed and how many people are actually getting sick. And then from confirming that there's an actual outbreak, once you confirm, you want to ensure that you notify the relevant persons who need to know that, yes, there's an outbreak ongoing. And also at this point, for any healthcare providers within the region who may see people turn up and they're ill, advise them what is happening and what they should be looking for. Because many of the things are maybe happening simultaneously rather than, even though it's 10 steps, recognize that some things are being done at the same time. But once we've confirmed the outbreak and we're trying to verify diagnosis, based on based on the constellation of signs, symptoms, and the results that we may have from any investigations that have already been done. And then we want to do our own assessment of the individuals, which would be included in the third step, which requires you to kind of have a handle on who is sick, what the symptoms and signs are. If samples have not been taken at this point, you would want to initiate the collection of samples. At this point, you would also want to, if there are still samples of the food itself that is left behind, then you want to also look at samples of the food. You want to create your case definition. So you want to know what are the inclusion and exclusion criteria, who is a suspected case, who is a confirmed case. And then, of course, in all of this, you're also trying to relate cases. So as you're collecting your information, you're trying to figure out what are the common grounds within the persons who presented. What do they have in common? Do they have a common exposure in this case? Does the onset of illness coincide? And from all of this information, then you're going to formulate a hypothesis as to what the likely source was, the cause is, and then of course you want to now look at you're looking at then you want to, because you're doing the investigation, you want to decide on what are the standardized forms you're going to use to collect your data to ensure that everyone is collecting the same information, which is important for your analysis. At this point, you want to be able to compare the persons who got sick with those persons who might have been exposed but did not get sick, or might have been present but are not ill. And that will help you to narrow down what the possible source is. For example, if there were 3 different samples that were being issued and some persons had sample 1 only and they are not sick, or some persons had sample 2 and 3 and they became sick, to kind of identify exactly where the source and so on was. And then, of course, you want to analyze, based on this data, you'll be able to come up with what the attack rate is. And then this is a whole lot. You want to formulate your conclusion based on all the information that you've gathered. 9 talks about putting control measures in operation. As I said, a lot of this is happening simultaneously, because even as you confirm an outbreak, you want to immediately decide on, based on this outbreak, what should we be doing to contain it? It would include, maybe, now that you know where the source was, ensuring that the company discontinues any further sampling of these products. You want to also look at, for the persons, it's foodborne. So you're talking about hand hygiene. You're talking about how to handle your infectious waste, vomitus. You're talking about, because you would also want to protect the family members who may also come in contact with the person. And when we come to this, we're also looking at identify cases within the household who may not have been present at the site, but may now have been, want to confirm if there's any spread outside of the primary source of the products. And then, of course, you want to, the final thing is writing your report. And in your report, you want to describe in detail the outbreak, confirming what the causative agent is, the number of cases, the attack rates. You want to give as much information about the outbreak as possible, but also included, you have to make sure that you have your recommendations are included. So it's not just describing, but also the recommendations that you want to include, which would control this particular outbreak, but may prevent further outbreaks.
Okay, very good. Group 1, so she went through the whole, group 2 went through the whole set of questions. So are there any additions that you would like to add? If not, we move on.
I think Nicole covered most of, if not all, of the things that we've mentioned.
Okay.
I mean,
So,
I'm not sure she meant, something was there about risk communication. I'm not sure she had mentioned if, the team would be going to the business place to, speak to the workers about that is, it's an ongoing investigation, but in the interim, you tell them the case definition to, like, if they're having symptoms, to find your nearest health center or healthcare provider, stuff like that, and to practice hand hygiene, as she mentioned before.
right. So as it worked out, what happened? So the implicated food was an eggnog. They use raw egg, and they would do it and serve cake, and they did overnight and froze it. And so what happened was it was salmonella in the end. This was identified through the stool, through the same genetics in the eggnog and at the farm. So we traced this one back to the farm. So, and it involved many retail places, not just the furniture store, but it involved supermarkets, wholesale, and really, because it's having alcohol, this thing about alcohol kill everything, and if you ice and if you freeze it, it kill everything. And what would happen? They would drive um to St. Catherine with the samples and then come back to Kingston when the stores in Kingston were open. So it was a very large outbreak in the end, not just the one place that called, and some persons were hospitalized. So for sure that was something that could be done. And the last few slides, in the last 15 minutes, I just want to, we need to look further than what is said. We see a cluster of infection, and first thing we're saying is an outbreak. So do we really have an outbreak? So, this cluster at university, we had eight babies with an infection and with one death. Is it an outbreak? Then we had Klebsiella at UWI. So we, more than just a cluster, we need to see what's behind the cluster. And usually, epidemic threshold is mean plus 2 standard deviation. So when we looked into the data, and we would have done the mean. So this is the mean. So it was right about the average, but because it was more than September, people were saying, oh, we have an outbreak. And the epidemic threshold is this green line, and it obviously didn't reach there. So it was but we looked at number of deaths, right? But then, apart from just looking at numbers, what we probably need to look at is death rate. So when we did that, it changed, okay? So what is the death rate? And we did a mean and standard deviation. So not just numbers, but rate, because after a certain amount, what happened, that the nursery may be closed. So there was another cluster at Cornwall. And when we looked at that, year on, so 2014, nobody was crying. In 2015, was there outbreaks in certain months? We really would have to look at the numbers and do. So at Cornwall, there was indeed an outbreak. And we look at number of deaths. And then when we did the rates, similarly. So there was indeed an outbreak. So, we need to look bigger. The other thing that was said was that, oh, it had persons dying throughout, the country. When we did the rates, the national rates, there wasn't anything. So what I'm saying, look deeper than what is you have to do the work. You have to do the work. I remember, people don't remember that, dead babies at Victoria Jubilee. This was a 2016 thing. When we did the data analysis, yes, in September, babies died. But this is the mean, so it was below the mean and below. So we have to do it. The other thing that we need to distinguish is between a seasonal changes and outbreaks. So we have a influenza season, we have a dengue season. So we have to be looking at the information by time. So if we took the respiratory system, so right now everybody says, oh, the bad flu, we're in an outbreak of bad flu. But are we? So what we need to look at, we do systematic surveillance for influenza-like illnesses. We have sentinel sites throughout the country. We have SARI sites, and COVID-19 is still a class 1. And then there's viral identification at the National Influenza Center. We are also part of a global network. So when we looked at, so this is current information. Influenza-like illness is collected over 3 age groups. So this year, yes, we are more than we were last year, from sometimes twice as many cases. But only 1 year that we hit the seasonal threshold. So seasonal threshold is calculated by an average of all the weeks. So for this, we would have 20 years, all the weeks, and we get a mean. So the seasonal is when it goes over this yellow line. When you look at the 5 to 59, you can see we did go seasonal and almost approach alert threshold. For 60 years and older, we went above the seasonal line, but not reaching it. But we do look at it at parish level, so certain parishes were having greater than usual amount of cases of influenza. Then we look at the SARI. So already this year, we have SARI admissions that went above alert level, above seasonal, and it appears that it is now below seasonal. Similarly, when we do percentages of SARI admission to the hospital, we know like at 0.7% of all admissions and below seasonal. So the worst seem to be week 1 and 2 and the end part of 2025. So, we are seeing more cases than last year, but based on the information, the data we have, we're not in an outbreak. Although you hear a person speak, we're in outbreak. When we look at COVID-19, SARS-CoV-2, what we have seen, the pattern we are seeing is that in May, June, we have the peak of COVID over the last 3 years. I don't know why. Also 2023, 2024, 2025, yeah. last 3 years. So it seems that COVID season is May, June, and influenza season is October to April, thereabouts. Then the other area we look at is the viruses and numbers identified. So this is week on week, starting last year. So SARS-CoV-2, May, June, April, May, June. Then coming to the end of the year, we're seeing influenza, RSV, and then the latter part, influenza A, H3N2, and which is predominating. So there were a time when we had COVID, when we had those non-pharmaceutical intervention, the wearing of masks, etc., etc. We had no influenza, but now we do. And this is the positivity rate for influenza. It might change over time. So the black is the average curve, and the blue is what we have been seeing. So it appears that we are seeing the worst. And then when we look at the 4-weekly average we see we went up at the beginning of the year, end of last year, beginning of the year. We are coming down now, but influenza A, H3N2 is there. So when we look at the percentage, you're seeing SARS-CoV-2 is predominated with some amount of RSV. So that's important. So we are below epidemic level, and but while we were more than last year, we are not in an outbreak. And we have reported no deaths have been reported yet from SARI. But as you can see, it's always greater sensationalism to say we're an outbreak. For dengue, similarly, there are dengue seasons, and we were in an outbreak 23, 24. And right now we're all green. And so that is it in a nutshell. Any questions? We have 5 minutes.
Yes, Doc. Can you go back out
Sure.
several slides to there was a slide where you had influenza-like illness, and then, well, several with different age groups. You had less than 60, well, over 60, less than 5, or something like that.
You're, oh,
Yes, see now.
let me just go to the correct.
Right,
These are
these slides. Right. Less than 5. Okay, so you were saying that this is not an outbreak.
Right, because the alert level is mean plus 1.67 standard deviation. And outbreak is mean plus 2 standard deviation.
Deviations, right.
What is this yellow line is a seasonal line. So when you go over that line, you would say we are in the flu season. Whatever. Or influenza.
Okay, and then right. Well, the next one.
Right. So this one now, 5 to 59, we did approach alert level.
Mm-hmm.
And if you see, we are probably more than twice the numbers that we saw last year, but still, it's just a more active season, but we're not in outbreak level.
Okay, and then
This is 60 years and above.
Right. And then the SARI hospital admission slide. Alert show. I think there was another one.
Yes, this is a percentage.
Right, this one.
Mhm.
Sorry, 2025. Oh, okay. I was misreading it. It says 2025. Okay.
Okay.
I was looking at the color as 2026, but
So
it's
the
2020.
pink one is 2026. So we did,
Right.
so one week we went above, but you can't call an outbreak rate and 1 week above for one of the indicators. So you'd have to look at the ILI, SARI, plus the percentage of the positivity for influenza. So at that time, we had RSV and influenza. So the positivity for influenza was actually low. So you can't then say you have an outbreak of influenza, if you understand what I'm saying, because they had other things at play.
Right, not just influenza.
Yeah.
Right, understood. Thank you.
Mhm. Yeah. Any other question?
Okay, Miss.
Yes.
I don't know if I've missed it, but I would like to know up to what age does the BCG protect you for?
It's infancy
Okay.
for miliary TB. That's like disseminated tuberculosis.
But on that note, then, in terms of the outbreak investigation, because the
TB?
case that we had, right, the TB case we had, was 16-year-old, 17-year-old, the fireman, which was an adult. Would the BCG vaccination status then be, well, how important would that consideration be in the case of TB specifically, as opposed to another, disease where the vaccine is protective for
Right.
an adult population, where in the cases we're considering are actually the age group beyond the infancy?
So so really the TB tells you how to read the Mantoux test or the skin test, tuberculin skin test. Because if you have had BCG, the reading, you can interpret it a little better. Some places, so that's one of the reasons, like some developed countries don't give BCG anymore because their TB rates are low, and then it protects you only from miliary TB. So the chances are to get miliary TB, you have to be born in a household with TB. And so the risk are low. And so that's why, and then to interpret the tuberculin or Mantoux test, then that's where your BCG history is important.
Okay, thank you.
You're welcome. All right. Thank you for attention. Unless there are any other questions, let me just look in the chat to make sure. Okay. All right. Have a good evening, everyone. Bye.
Thank you. You too.
Yeah, bye.
Okay, I'm trying to find out if anybody received the case, the botulism case. Not hearing. Denise,
Yes, I received the case. It was shared in the WhatsApp group. I'm not sure if it was sent by email to everybody.
Oh,
I didn't receive an email with it. I received it in the group chat.
okay, because that was the purpose of tonight's class. All right, so I'm wondering, okay, I could give you half an hour. It's difficult if you haven't reviewed it. Okay. Let's just read through and I guess we will try to go through as much of it as we can. Can you see the screen? So usually you should have gotten this case. I understand from Candice, it was sent out by Jody, who is the class rep. And then normally we go through as a go. All right, so I'll just read through and it's based on participation. So it's a case of foodborne botulism. And you would have gone through with Dr. Webster earlier about outbreak investigation. So this is an actual case that occurred that we'll work through. So botulism, foodborne botulism is a severe illness that results from the ingestion of a preformed toxin produced by a bacterium, Clostridium botulinum, in contaminated food. Death can occur in up to 60% of untreated cases. Supportive care and prompt administration of antitoxin can reduce mortality in the US to less than 10%. Outbreaks of botulism have been linked to improperly preserved vegetables, fruits, and meats, including fermented fish products, sausages, smoked meat, and seafood. On January 13, 1998, an infectious disease physician at Buenos Aires Hospital telephoned the EPI unit at Argentine Ministry of Health to report 2 possible cases of botulism. The patients, both men, presented with drooping eyelids, double vision, difficulty swallowing, and respiratory problems. One patient had onset of symptoms on January 5th and the other on January 6th. The physician had drawn sera and collected stool specimens from the men to test for botulinum toxin, but no results were available. So you received a report on 2 possible cases of botulism, a serious illness. We said that you can have death in up to 60% of cases if untreated. And the treatment is prompt administration of antitoxin, similar to tetanus. So as a public health practitioner, what are the major concerns raised by these 2 possible cases? Are you concerned?
Yes, I'd be concerned and I'd question, where it is they got the food from, how much other persons actually ate the contaminated food, and then there are different options as to what could cause the botulism. So we'd have to narrow it down to find out exactly what it is they would have consumed, the 2 cases so far.
Okay, and why are we particularly concerned and need to act quickly in this case?
Is a high death rate from persons who contract this bacteria.
Repeat? Councillor Daniel?
So in untreated cases, death can occur in up to 60%. So this is definitely something that we want to look into.
Right. Okay, so yes, so the severity And as Aliyah mentioned, you have a contaminated food source, possible contaminated food source. You have a severe illness that can result in death. There's a possibility, therefore, that not only the severity, that there can be illness in others. So a single case of foodborne botulism is a public health emergency that might herald a larger outbreak. And therefore, we have to act quickly, including an immediate search for other possible cases, and as was mentioned, to identify the food source, as well as we said that these are possible cases of botulism, so we want to confirm the diagnosis as well. Let's go to part 2. The clinical syndrome of botulism is dominated by neurologic signs and symptoms. Dryness of the mouth, drooping eyelids, blurred and double vision are usually the earliest complaints, neurologic complaints. These are followed by disturbances in speech, difficulties swallowing, and peripheral muscular weakness. If respiratory muscles are involved, you can have ventilatory failure and death, unless supportive care is provided. The average incubation period for botulism is 18 to 36 hours, but symptoms can occur as early as 6 hours or as late as 10 days after exposure. Because botulism is rare, many physicians are unfamiliar with its presentation. As a result, patients with botulism can be misdiagnosed as other illnesses such as stroke, myasthenia gravis, Guillain-Barré syndrome, delaying the administration of life-saving botulinum antitoxin for days, and of course that results in an increase in mortality rate among cases. So how would you go about swiftly determining if there are other cases of botulism associated with these 2 cases in Buenos Aires?
You may want to look at other hospital presentations that may have been diagnosed with some of the other neurological presentations.
Okay, so you want to contact your local hospitals, emergency rooms, ask if there are similar cases of acute neurologic illnesses, because as you said, it may be misdiagnosed. So you're going to do some active as well as passive surveillance to identify these cases that may have occurred. Anything else? Not only contacting the hospital, but you'd actually review the admission and emergency room logs for patients admitted with some of these neurologic conditions, stroke, myasthenia gravis, etc., and follow up to determine if botulism is a possibility. Anything else?
For the individual cases, you want to also get the background information from them to see if there might have been a common source for exposure, and then that would help you to identify probably possible exposure groups.
Okay, so very important, of course. You want to, first of all, talk with the patients, identify common meals and other persons who may have shared them. You may also want to talk with their family members and friends who may have shared meals with the cases, and ask if they have signs or symptoms of botulism. You may want to talk with co-workers as well. So, and then we said we're looking for cases. So we said contacting hospitals and emergency rooms. Where else can you find cases?
The health centers.
The health centers. Anywhere
Private
else?
physicians.
The private physicians, don't forget the private doctors. So you contact your local physicians, including your neurologists, to see if there's anybody presenting with symptoms and signs suggestive of botulism. Anywhere else that you can identify cases, so you're, hurriedly trying to identify possible cases.
Nursing homes? I'm not sure.
Repeat.
Oh, I was wondering about nursing homes.
Nursing homes, okay. Possible, but think broader.
Like, I guess surrounding territories.
Okay, not too broad. When you say surrounding territories, what do you mean?
I mean, I guess too broad because I was thinking like surrounding countries or whatnot. But
Okay.
um
So we said doctors' offices, private, public, emergency room. Talking to the patients, the family members. What would be where else? Okay, one would be the laboratories. So laboratories that do testing for botulism. So you know to ask for notification of all requests. But what would be an example in this case of okay, so
Maybe
what
where
about
they got the food.
okay, so we will eventually go and talk to those persons, but what about the public? What would you do? So not everybody might reach to the doctor early or at
Media
all.
could
sensitization.
set up like a hotline to see if it is that persons could call in with symptoms.
Okay, so that is all part of it. We need to notify the public of the outbreak through various forms of media, newspapers, radio, television. Remember when COVID hit and we had to tell persons if they have fever and cough and shortness of breath that they must go and get tested, right? So similarly, if you're looking for cases, you want to also sensitize the public that if you have these symptoms, that, to contact a healthcare provider, or it could be a hotline. What might be the concern about using media to sensitize persons about botulism?
I just kind of
You
make
don't
them
want
more
to
conscious
scare the
to understand.
public, so you have to be very careful how you communicate the information.
Right, right. So you don't want people to panic. And sometimes you set up a hotline and too many calls, or the emergency rooms become overwhelmed, which occurred during COVID as well. So you have to tailor your message very carefully. But note that in this case, you're doing both active and passive surveillance. So you educate the public and you give them instructions what to do if they have certain symptoms, but you're also going out to the hospitals, to the emergency rooms, to the physicians, to the laboratories. You not only rely on them reporting cases, but you also will do some active surveillance. All right, the directors of the National Laboratory and the Environmental Health and Sanitation Program were notified of the possible cases of botulism The two patients still in hospital were interviewed by a Ministry of Health epidemiologist. Upon questioning, it was learned that both patients were drivers for the same bus company and drove the same route and shift. The patients knew each other but worked on different days of the week. They had not eaten together in more than a month. To find additional cases, the Ministry of Health contacted all employees of the bus company with the ill drivers to see if any had symptoms suggestive of botulism. Hospitals in the area of Buenos Aires, where the two cases occurred, were asked to report any patients with acute neurologic illnesses that could be botulism. Family members of cases were questioned about whether they also had symptoms of botulism. Additionally, the MOH developed a press release for distribution to the local news media. What are the key points would you include in the press release? Let me hear some additional voices. I heard Nicole, Daniel, Leah, anybody else want to tell us what would you put in this press release? One. Anybody? What would you put in our press release? You want to give information about botulism to the local news media. So the purpose is to identify cases of botulism, which might be connected to the two cases that were reported.
The general symptom of it, but then also it also want to kind of say
You're cutting out Daniel.
so I was about to say if you might know anybody.
You're a little choppy. I heard general symptoms, right? So you want to let them know that these are some typical signs and symptoms of botulism.
I also had like a brief description of the current cases without revealing any personal information, as well as when they should present to a hospital or for testing.
Okay, well, we want once you're suspected to see a healthcare provider, and yes, you want to tell the public that there were two cases of botulism or of a potentially fatal disease in the community, and you could state the date of illness. You could state the location, but again, you have to be careful about how much detail you give, but certainly the location would be important. You will also recall in COVID when they had cases in a certain community, there was stigma associated with the community. But it's important to state, where, when, who, what, why. So we said two cases, we said the signs and symptoms.
We also should probably consider reassuring persons that it is being managed to prevent scare.
Okay, so you want to say that, if you have the problem, that it can be managed, but you need to do what? That's specific information what they should do, right? So you give a contact name, telephone number. Daniel had mentioned you could set up a hotline so that you have means for persons to, ask questions. And of course, very important, you have to tell them where to go if they think they are a case, right? So You have to give that basic information that you have identified 2 cases of a potentially fatal disease in the local community and that you need to identify additional cases so that investigation can be undertaken and treatment given. And if there is a source, identify that it can be recalled and destroyed. And of course, as we mentioned, you want to tell persons where to go if they think that they are a potential case. So the next, who should be involved in developing the press release or at least notified before its distribution? Who are the stakeholders in this? Who should be involved in the press release?
The relevant ministries.
Okay, so of course, the relevant ministries, which might be, of course, the Minister of Health, certainly. Remember, you're in the health department somewhere. You need to tell your Minister of Health and your communications team for the ministry.
I'm not sure if you see the chat, but someone in the chat is speaking. He said the Chief Medical Officer, the Epidemiology and Surveillance Unit leads. He also said the National Public Health Lab.
Yes, very important. So all of the above, certainly the public health lab, because remember, they will be doing the testing of sera and of food specimens as well. The health departments, any food regulatory agencies, and of course, in this case, where are they suspecting the problem is? The 2 cases.
Oh, the bus company.
The bus company. So the management of the bus company is also an important stakeholder, and professional groups. Okay, so let's look at the press release. On January 14, the Ministry of Health distributed the following press release. On Monday, January 13, 2 bus drivers, Pablo Esteban and Juan Rojas from South Central Buenos Aires, were diagnosed with botulism by an infectious disease physician at Hospital F.J. Muniz. The men had been ill for several days before the diagnosis was made. The attending physician, Dr. Jorge San Juan, reported that botulinum antitoxin was requested from the U.S. Centers, U.S. CDC last night. Because botulism is potentially fatal if untreated, the Argentine Ministry of Health is working with local public health officials and healthcare providers to identify the source of the botulism. Officials worry that other persons may have been exposed and need treatment, or that the source may still exist and cause more people to become ill. Botulism is a rare but serious paralytic illness caused by a nerve toxin produced by a bacterium, Clostridium botulinum. The symptoms can be easily confused with other illnesses and include diplopia, ptosis, dysphagia, dysarthria, and muscle weakness. If untreated, these symptoms may progress to cause paralysis of the arms, legs, trunk, and respiratory muscles, and ultimately death. If diagnosed early, botulism can be treated with an antitoxin which blocks the action of the toxin circulating in the blood. Previous outbreaks of botulism in Argentina have been caused primarily through eating improperly preserved vegetables and meats. Implicated foods include ham, red and green peppers, bicasha, an Andean rodent, eggplant, cucumbers, palm hearts, tomatoes, peaches, spinach, and a type of cheese with onions. It is not yet known what specific food may have caused the botulism in this outbreak, but both men are bus drivers for the same company, Ariba Bus Inc., and drive the same route and shift. Persons who feel they or their relatives might have symptoms of botulism are asked to contact the Directorate of Epidemiology of the Argentine Ministry of Health at X, Y, and Z. So the question is, critique the press release. How might the press release impact the outbreak investigation? What do you think about this press release?
They gave the gentlemen's names.
Right. So of course, that's a big no-no.
As well as I think they confirmed that it was 2 cases when early on it didn't say that the results came back, if I remember correctly. So it's saying that the cases are confirmed. I think that's what they're saying.
Okay. So they breach confidentiality or privacy by giving the names. They say that the diagnosis was made when it wasn't. Anything else?
I think that they use a lot of medical jargons
Yeah,
when
I agree
about
too.
symptoms that they can be confused with. I mean, no local person is gonna know what dysphagia means or anything like that. So they could have used simpler language that a
I think
person should
they could have
understand.
used the same terminologies, but then as well as include what in layman terms, so the public
What
could
they are.
understand what it is.
All right, so they shouldn't be
Don't
using
think
all
they
that.
include the same, yeah. They don't need to use the same terminology, like the medical term and then the layman term, just use the layman term.
Yeah, well, yeah, they don't need to put the medical term at all. Remember, this is a general public.
And I think that they probably gave too much information. Like, oh, it can go really bad very quickly. It sounded like a scare tactic to me.
Okay. Anybody else? Shanice? Oh, Nicole, you were saying?
Yes, I was looking at, well, I was going to say something about medical jargon, but also near to the end where it speaks specifically to the routes of travel and the bus company and so on. I thought that could really impact in terms of the business, ridership and all those things that might not have been necessary because the taxing isn't necessarily going to be jumping from person to person on the bus. So that might not have been necessary.
Right. So
Given just the geographical area and the types of food, I think would have sufficed.
okay, so that's right. So you may have caused unnecessary panic and stigma, just driving on this bus on that route. And I guess this was mentioned. What do you think about the length?
This was too long.
It's too long.
It's just Scipio.
It could have been very
Especially for the public.
concise.
Right. The public don't,
Yeah,
have
they're
to.
not gonna read all of that.
Right. So it's way too long. What do you think about the last line about contacting the Directorate of Epidemiology? So in
They
Jamaica,
could have said contact your local public health facility.
right. So it is very specific, as we mentioned. The signs and symptoms are non-specific. You could have a deluge of calls to the epidemiologist, to Dr. Webster. So it might be better, as we mentioned, to say contact your healthcare provider or contact a healthcare provider that can make the diagnosis and initiate the appropriate care and report to the Ministry of Health. So in summary, too long. I shouldn't have used the patient names. It is good that they give some information about the condition and the need for quick treatment. We mentioned you shouldn't be using medical terminology such as diplopia and ptosis and dysphagia. The jargon will prevent readers from understanding. And we didn't think use of bus drivers from Ariba Bus Inc. Might even cause some selection bias too, because not only scare persons from using that bus route, but then also persons might think, oh, I didn't go on that bus route. I'm not associated with that company. And so even if I have some symptoms, because I'm not associated with that bus company and route, it is not botulism. So, and similarly, the physicians might also be less likely to test because now you've put it out there that this is the bus route with the problem. So it could also lead to some selection bias. So 7 additional patients with neurologic signs consistent with botulism were identified. 5 of the patients had sought medical attention, 4 were hospitalized. Working diagnoses at the time of the initial 2 cases that were discovered included myasthenia gravis in one, Guillain-Barré for 2, stroke for 1 patient, and diabetic complications. Botulinum toxin was identified in sera and or stool from 3 patients, including one of the original cases reported on January 13. All patients were drivers from the same bus company as the original cases and drove the same route. From initial reports, all had eaten at a home located at the terminal stop of the bus route where the drivers stopped during their breaks. Approximately 58 bus drivers worked this route, 27 in the morning shift, 16 in the afternoon shift, and 15 in the evening shift. Would you initiate any control measures at this time? What criteria would you consider in implementing control measures so early in the investigation? So will you do anything or you just continue to let the bus drivers drive that bus route until you do your study and identify what the cause of the outbreak is? What do you think? Any thoughts? Are you going to continue to let the bus company operate as usual? Do you go in and say, let's halt activities?
So there's a few things that we would definitely have to consider, the economic um gains or losses that, the bus drivers would also face, and then the disruption of transportation within the area. So, but then we also have to balance that with the public health needs. And so perhaps one of the things we could do is look to either change the route to bring it close enough to certain stops, or we could just, perhaps say we'll continue the route, but the last 2 stops you won't do, which would include that area where we suspect that they had the lunch. So that is, we could look into, you know, giving an alternate route that wouldn't disrupt the area too much. So passengers or persons within the community still could get about their day. And then we could also either just stop the route early to limit further spread while we do the investigation to establish, where it's truly coming from, etc.
Okay, so important points. And I'm not sure if there are any public health inspectors in the class, but always weighing the impact on, as you said, transportation and persons' jobs, the economic impact. But on the other hand, the severity of the illness. So, given what we know about botulism, urgent action would be needed. You mentioned taking different routes or shortening the routes, but what is the problem? Is it the route or
The food source.
the food source? So we could continue the route, and what do we do about the food source?
I think operations should pause until, the necessary testings have been done to confirm whether or not that is the source.
Okay, so yeah, so that we could do because of the seriousness of the action. But as Alicia mentioned, you do have to consider, so it's a balance of how urgent public health, I mean, you have to intervene in terms of you will, at a minimum, want to follow up all the bus drivers to make sure no others are ill and that they get whatever diagnosis and treatment. And you certainly want to follow up the home where the persons were eating. And the big question is, do you suspend operations or not? So in this case, we would say you would consider suspending commercial food services at the home or asking them to suspend the services. That's also a possibility until you can gather more information. All right, everybody agrees? And it's
Yes,
fine,
Miss, I agree.
Yes.
fine to disagree. As you can see, it can be a tricky situation.
Just to say there are some messages in the chat.
Okay, somebody can read for me because all right.
All right, I'll read. So this is Thorpe. So he's saying yes to would you initiate any control measures? He stated that he would do laboratory confirmation as there are multiple additional cases with clear epidemiological connections. Definitely shut down the food sources right away, especially because there are 58 drivers who are potentially exposed. And just a reminder that the botulism has a high fatality rate and it outweighs everything.
Okay, so the severity is what tips you to the other side of suspending food the services at the source, or what we think is the source, at the home where the persons ate. So the severity of the disease, the population at risk. A very important point too is whether you think exposure is still occurring, right? So if it was a one-time exposure, that is, a different thing than whether if you think that the home or the place where the food sources, that they're still preparing that food. So you will have continued exposure. And also how easily control measures can be implemented. Does it require a nationwide action? In this case, it's more or less localized, so that makes it a little bit easier. Okay, so from the health department, of course, with your outbreak investigation, you're going to collect information, and they were asked to provide demographic and clinical information on the patients. So as usual, they can collect information on the age, on the gender, when they worked, when their symptoms occurred, and the symptoms that they experienced. So I will ask someone to just summarize the demographic and clinical information based on the table. And I'll give you 5 minutes to draw an epi curve if you haven't, because it's good practice.
Doc, could you repeat the instructions, please?
I want somebody to summarize the demographic and clinical information on the patients, and then you're to draw an epi curve. So maybe you can start by just summarizing for me, and then I'll give you 5 minutes to just sketch your epi curve so that you get the practice. All right, who wants to summarize? Or tell me one line about the data, about this, one line of the summary.
So there were 9 suspected cases. The age range was between 23 years old to 54 years old. They were all males. They all worked the morning shift. The first set of neurological symptoms was from as early as January 5th to as late as January 15th. Common symptoms included drooping, amongst all of them. That was common was drooping eyelids, and then the other symptoms would have included blurred vision, double vision, fatigue, respiratory difficulty, etc.
Okay, excellent, except the etc. All right, so you said the cases occurred from January 5 to 15. What about the median age? You mentioned the age range. What's the median age? On in the chat, but it's hard to monitor.
It is 44.
40 years.
40, 44. Which one is it?
We're trying to put them in age order. So we've got 24. There are 2 persons with 31. That brings us to 3. And then 42 would be 4. And then 44 would be the 5th. So I'd say 44.
Or it's between 40 and 44, 42. I have 42. But I'll take your word for it. I did it long ago.
It says 42 to use
Okay, somebody else got 42. So the age range is 23 to 54. There were 6 with blur. All patients had ptosis, as you said. 6 had blur vision, 5 fatigue, 4 had double vision. Okay, so I'll give you, do you need 5 minutes? It's 7:49 at 5 minutes to just draw an epic curve based on the information. So remember, in our epic curve, the x-axis would be your date of onset and your y-axis the number of cases.
Hello?
Oh, you need to see it. You should have a copy of the handout. I was going to pull up my own epic curve so you can see what it looks like.
No,
Everybody.
I was just checking. I was just checking my mic. I was the one typing in
Oh,
the chat, but I switched. I was trying to switch over devices.
okay.
But yes, my mic is working now, so I was just checking.
Okay. Can I stop sharing? You have the information.
Yes, Doc, I have it. Thanks. I just wanted to add to the summary, the bus drivers, all of them are all bus drivers.
Very important, yes. That's critical information, yes. Okay, so I'm going to share what your epic curve should look like. Everybody has something looking like this. Is this what your epic curve looks like?
Yes, that's all. Yes.
Right. So is there a peak of the outbreak? Although the answer is right there. Would you say there's a peak?
Yes.
No, there's no real peak. Yes, there's one day that there's 2 cases, but it's not your typical peak. So they say the average incubation period for botulism is 18 to 36 hours, but symptoms can occur as early as 6 hours or as late as 10 days after exposure. What was the most likely period of exposure among these cases? So if the incubation period is 18,
Well, I'm thinking it would be not the earliest would be the 3rd, but it was probably the day before. So between the 3rd to the 5th, or maybe the 4th to the 5th. I'd say the 3rd to the 5th.
Third to the fifth or fourth to the fifth. Anybody else thinks differently or you're in agreement? You want to tell us how you came up with that? What was that?
They said the incubation period
But it could be as
18,
early.
18 to 30, but early as 18 up to 36. So if you take the first person that came on the 5th, well, the two people minus 1 day, so 24 hours before would have been the 4th. You go back 36 hours would be the 3rd. So the furthest back you would go you couldn't go back to the 2nd.
Mhm.
So
Okay.
the earliest would be the 3rd.
Okay. So they said it can occur as early as 6 hours or late as 10 days. So if a point source is suspected and you have the time of onset of illness, then you identify the first case and count back the minimum incubation period, which was 6 hours, as you said. So the first case was day 5. So that point exposure would have been maybe day 4. And then you also look at the last known case in the outbreak, which was what? On the 15th, correct? Last known case was the 15th, and then
Right, yes, that's
and
right.
then you count back the maximum incubation period, which it said was 10 days after exposure. Therefore, the exposure is likely to be between the 4th and the 5th. Everybody agrees and sees how we got to that point?
Yes, I agree.
Okay, so we looked at the last case and the maximum time, 10 days from January 15th would take us to January 5th. And they said the minimum incubation period was 6 hours. So that first case, that would have been an exposure of 6 hours before. So somewhere between the 4th and the 5th is where we think the exposure occurred. Right? If there was a peak, then you could count back the median incubation period from the peak of the outbreak. But in this case, we don't really have a peak. Okay, so let's move on to the next question. So we summarized our information, we drew our epidemic curve. We said that the most likely period, because we know what the range for the incubation period is, that the most likely period of exposure was somewhere between January 4th and 5th. So in hypothesis generating interviews with cases and other bus drivers, so we said there were 58 bus drivers, we have to interview them. Being a driver on the morning shift of the bus route and eating at the terminal home of the route were the only common exposures among cases. No cases of botulism occurred among bus drivers from the afternoon or evening shift of the route. Bus drivers from those shifts did not usually eat at the terminal home because it was only open for lunch. The investigators hypothesized that the outbreak was limited to morning shift bus drivers and resulted from eating or drinking something at the home at the terminal stop of the particular bus route between January 3rd and 7th. What type of study would you use to investigate this hypothesis and why? So he
First
said,
thing that jumps out at me is case control because we have cases.
mhm. Okay, so you could use a case control, or what else could you use?
I guess retro. It's a case control.
So as you said, we have cases, persons who were ill and persons who did not become ill. So we could do a case control study to test our hypothesis. Is there any other study design we could use?
Retrospective cohort as well then, because we have cases.
Yes. So we have cases and control, but we could also do a cohort study, right? We have a cohort of bus drivers on a particular route and shift, right? True? What would be the advantage of doing a cohort study? What's the measure of association you can calculate compared to an odds ratio? Oh, I gave the answer. So in a case control study,
The case control, right? I was thinking that.
yes, you would calculate the odds ratios, right? Whereas in the cohort study, what can you calculate?
Relative risk.
Relative risk.
The relative risk, you can calculate attack rates and incidents. You can calculate your risk, your relative risk. So it results, whether you do case control or cohort, but the advantage of the cohort is the ability to calculate attack rates. But either way, results from the studies could provide important information on the source of outbreak and therefore how we control it. To identify the source of the outbreak, the investigators undertook a retrospective cohort study among bus drivers who drove the morning shift of the bus route. Data were collected from January 15 to 19. Investigators defined a confirmed case of botulism as a bus driver from the morning shift of the bus route with a serum or stool sample that demonstrated botulinum toxin or yielded Clostridium botulinum with onset of symptoms between January 5 and 15. So that's their case definition. A probable case was defined as acute cranial nerve dysfunction, such as blurred vision, double vision, drooping eyelids, problem swallowing with no laboratory confirmation in this group of drivers during the same period. The comparison group consisted of all bus drivers from the morning shift of the implicated bus route who had no acute neurologic symptoms suggestive of botulism. After consultation with the local health department, where the terminal stop of the bus route was located, and the bus company management, investigators developed a structured questionnaire for the epidemiologic study. So they have their cohort of bus drivers on the morning shift of the implicated bus route. And they developed a questionnaire. What information would you include in the questionnaire?
Just a quick thing, Doc. I'm not sure if I missed it, but did we ever say they were female bus drivers? Or it was never said?
They were all males, I believe,
They
from
were
the
all males, yes. Remember on the table, the initial investigation of the 9 cases, those were all male. All right,
Right, but
mhm.
no, just in terms of, because when we're collecting demographics, well, I'm thinking to start to say, what we're including in the questionnaire is going to be the demographic data,
Right.
the age, the sex, and so on. But I mean, if I was just thinking, if they only have male drivers, I
Oh, no, we
mean,
don't know that. No, we don't know. So yes, you need to
right.
first of all have, even before your demographic information, what do you collect?
I guess their name.
And then the
I mean,
consent.
The name.
Oh,
Well, yes,
name.
of course, yes, correct. You should get consent, but first thing is your name and some
name.
unique identifier, whether it's a medical record number. Second would be your, because remember, you have to link not only questionnaire, but you may want to update information as well as you need to link it with what? Your lab. They're going to
The lab.
need it, right?
Yeah.
Yes, this is just a questionnaire. So we're going to get objective evidence of botulism. So identifiers, then we get your demographics. So as you said, the age, the gender, you may have address, location. In their case, they had race or ethnicity because, and we collect that information as we did in COVID because we want to characterize the risk factors, examine possible confounders, right? So who is at risk for the information? So what else?
Their
We said
exposure
contact info.
history,
Okay, I heard
food
his.
exposure, and maybe like their clinical history.
Okay, clinical information. So their signs, their onset of illness, anything else as far as clinical information. So whether they had the droopy eyelids, whether they had problems with speech.
Um, pre-morbid, any comorbidities. If I'm not sure if that's relevant,
Yes, yeah,
but
we
maybe
usually. Mhm.
if they have other illnesses.
Maybe if they had taken any medical treatment.
Yes, very important outcome. So whether they saw a doctor, whether they were hospitalized. So we did the same thing in COVID. Want to know, did you go to the emergency room? Were you hospitalized? Were you admitted to ICU? So, and of course, we also want to know if they had any lab tests done and results. I think I heard someone mention foods eaten, so not just clinical information. You also what foods were eaten. You mentioned medications, underlying medical illness.
Yes, but on that note of food even eaten, going back up before clinical information,
Mhm.
um, in terms of our summer, because it was morning shift, I'd say we'd have to include like if it, are they like in terms of excluding or seeing who is, eligible or directing our focus then, because it was all of them were morning if I recall. Not even mostly, it was all morning and
Mhm.
in terms of because and if we're saying they are most likely exposed, um, the food place was the earliest would have been the fourth we said or the third. If a driver worked say on January or December, I don't know. I mean, 20 something versus
Mhm.
one who worked on January 6th, you know. I guess we'd want to know before even going into the clinical information, were they on the morning shift at all? Did they work the evening shift? Did they work during the date? Right before we said there's no peak, but the earliest possible, even the incubation period, those little pieces of information given our summary.
Right. Right, so a little more detail about when they worked to try and localize the exposure. And of course, we want to know the source of the patient, so if of the information, if it's a patient itself or a parent or spouse, and who is collecting the information. Usually we want to record that as well. Now, question 9, what steps would you take to develop the questionnaire for this investigation? So we have a hypothesis, right? We identify our primary and secondary hypothesis. And we need to know the information that we need to accept or reject our hypothesis. We have to, and I'm just going through this one in the interest of time, we would list information needed for the logistics of the study. So, and how we would collect the information. And of course, we do our analysis plan, we write our questions, and we organize our questionnaire. And before we go out in the field, what do we usually do to our questionnaire?
Pre-test.
Pre-test our questionnaire, we revise depending on what we find, and then if we use interviewers, then we would train them. Okay, I won't go too much into this, but I will highlight some things about questionnaires. So in terms of when you select questions, so you want to know what the person had during the time of, so you asked, did you have black coffee, coffee with milk, hot dog, salami? You have a list of foods. Do you use check all that apply, or do you say yes or no? How would you capture the information on the foods that they eat?
You'd want to use some skip. I'd say yes or no because first we have a site, and I mean you'd want to know first. I mean if they ate or drank anything there.
Do you want to say, would you list everything you ate during that time?
Right, and then put yes or no beside. Well, that's an
What's the
Let me think.
advantage or disadvantage of? So you had the option of saying, list all the foods you ate while between this time period, or you could put a list of foods and ask them to check the ones that they had, or you could put a list of foods and for each one you have a yes or no answer.
The last one, because I'd say first. Yeah, I agree with the last one you said. That yeah.
I think there's a chance also that we may not include all the possible food options. So we may probably miss something.
Right. Yeah, so that's just a point. When you're doing questionnaires, you prefer for something like this to have close-ended questions. You can have a other category, but you might miss some important foods. So if you know possible sources or the things that are served at the home where you think the exposure occurred, it would be better to list the foods and to have a yes or no or a don't know response as well. The problem with check all that applies is that sometimes persons don't check things just because they missed it and not because they didn't have the exposure. So if you want to be sure that persons really read your questionnaire properly and answered correctly, it's better to have the yes, no, don't know option beside each one. You're with me? You understand what I'm saying?
Yes.
You're saying, oh well, I feel like I just want to be clear. And you're saying for even after putting each individual food item, instead of just having them say check all that apply, you actually ask them individually for each food item, did you or did you not? Or
Right.
or don't know if you're unsure, so that each individual item is clear, as opposed to them just ticking everything, and then
Right.
that would skew the outcome.
Right. So you said, did you eat or drink black coffee? Yes, no, don't know. Hot dog, yes, no, don't know. You're forcing them to answer for each food item.
Individually, right,
Yeah.
right.
Because often
Understood.
when we do questionnaires and you just put a list, they might not tick something, and it's not because it's not applicable, but they're just rushing through or it's an oversight. So your interviewer now, in checking over the questionnaire, if they reach hot dog and nothing is circled, not yes, no, or don't know, you go back to the person and say, you didn't answer this question. Did you eat hot dog or not, or you don't know? So it forces you to answer to each item. All right. If the investigators conducted interviews with each of the drivers of the morning shift of the bus route to complete the questionnaires, if the investigators had decided on self-administration of the questionnaire, what might be, I'm going to change this around. What are some of the things you would have to consider in a self-administered questionnaire versus an interviewer administered questionnaire?
Low response rate.
Low response rates, what would you take into account when you're designing the questions?
So it has to be um first I'm thinking literacy, because giving a self-administered questionnaire first assumes the person can their reading ability. You're assuming they can read and understand what you're asking them, and then as opposed to the interview administrator, the interviewer can on the spot read it clearly to them and break it down, and then the questions have to be very simple.
Yeah,
Well,
not
no
ambiguous
jargon.
or double barreled or anything like that.
Right.
Agreed, right, right. Not loaded questions, because then they're gonna misunderstand or confuse it, as opposed, because there's no interviewer there to explain unclear questions, so they'll just select something, you know. Yeah.
Right. So the questionnaire should be short as possible. Have you ever gotten a questionnaire by email and you start answering and then you just give up? That happens to me all the time. The people doing a survey and they send you a questionnaire, and you think it's 5 questions and it's just going on and on and on. So the questionnaire should be as short as possible. The wording should be, as you said, easily understood, free of technical words or jargon. So in an interviewer administered questionnaire, as you mentioned, you have the benefit of clarifying things versus the self-administered questionnaire. You shouldn't have abbreviations. And when you think of your questions, you have to ensure that you have all possible responses, anticipate and prepare for possibilities. So be sure to include a don't know category. And I've seen that with the DRPH theses as well. people doing up questionnaires, there are times when there is neither a yes or no response. So you have to ensure that you have all the possible responses for your questions. And of course, earlier someone mentioned skip patterns. If it's self-administered, you keep skip patterns to a minimum because, of course, you can end up with people abandoning the questionnaires or they just don't get it. And remember, your pre-testing should be with persons who are similar to your study subjects so that you can identify and correct potential problems early. All right, I am going to give you a 5 minutes, 4 minute stretch break, and then you have 5 minutes to answer this part. So until 8:30, the following food exposure information was collected through the cohort study. On January 19, the information was tabulated by the epidemiologist. And I want to, well, first of all, we said it's a cohort study, so you can calculate the relative risk. So the question will be to calculate the attack rates for each food and the relative risk for each food item. So I want you to calculate the attack rates for those who ate bologna and those who didn't eat bologna and the relative risk. Or did everybody do this already? Was this done already and you don't need the 5 minutes?
I hadn't done it, Doc, so I'm doing it now. But
Okay.
I wouldn't want to hold up the class, so if everybody else do it, I guess we can proceed and I'll just follow along.
Okay, I'll give you till 8:30. So calculate for each one.
Sorry, Dr. Duncan. Remind me what we're calculating. You said the attack rate for each food.
The attack rate for each food, for attack rate for those who ate each food item and did not eat each food item, and then the relative risk. All right, let's start. If one, um, if different persons can take one food item, we start with bologna. What's the attack rate for bologna? Are you? Cohort studies measure of association is relative risk. If it were a case control, we would calculate the odds ratio.
4.8, 4.8%.
4.8. Attack rate for those who ate bologna.
No, for those who ate.
Uh-huh.
One person ate and
So how do we calculate the attack rate? That's the incidence, right?
right, so that's the person, that's one ill over ill and so under 8 it's ill over ill plus well.
So the number of
So
new
be
cases over the population at risk. So 1 over the total number of people who ate
21.
bologna.
so it'd be 1 into 1.
So 1 over 21, which
Where
would
again?
make it 4.8, not so?
No. Okay.
No.
Remember, we're doing the incidence of botulism among those who ate bologna, which would be the number of cases for those who ate bologna, which was 1, over the total population who ate bologna, which is 1 plus 0. So as I think it was Daniel who said it
Oh,
would be 1 over 1. So the attack rate for bologna is what?
100%.
100%. Correct.
got
And,
you. Okay.
and for those, the attack rate for those who did not eat bologna, so the incidence of botulism among all the people who did not eat bologna would be what?
67%.
67? What's the numerator?
Would it be 8?
8, correct. But what's the denominator?
Would it be 12? Or would it be
Total
13?
population.
Oh, it would be the 21.
20.
20.
The total population is 8 plus 12. We're
Oh, I'm
looking
sorry. I was counting the
at
one
the
that ate
1.
it.
Right. So
Sorry.
it's the total population at risk of
So it would be 40.
40%. Everybody got that?
Yeah, I got 40.
Yes, got it. No.
Right. So the attack rate for those who ate bologna, so all the people who ate bologna got botulism, which is 1 person. And all those that did not, and 8 of those who did not eat bologna, which was 20 person, 8 of 20 got botulism. So the attack rate in the group that did not eat bologna was 40%. So the relative risk, which is the ratio of the attack rates or the ratio of the risk or the ratio of the incident, is equal to what?
For that, I got 2.5 because it's so the exposed
So I say,
to the unexposed.
right, so it was 100 over the 40, right?
40, right? So 2.5.
Everybody agrees?
Yes, Doc.
Have to know how to calculate this for your exam, so pay keen attention. So you said 2.5. If I told you the p-value was 0.43, how would you interpret that? So the
If
relative.
if the p-value is 0.43,
That's not significant. That's greater than 0.05, no?
Right. So tell me in words, you have a relative risk of 2.5. What would you say about bologna? Bologna.
Um, so then there's a so
So
then
would
This is
we
where we're not
say that the
rejecting the
person,
hypothesis, right?
Yeah,
So
well,
do not reject. So there's no statistical significant evidence that
so it means that
bologna
okay.
so
a person do.
So Vanessa, go ahead.
No, go ahead, Akeem.
I was you start before. Let me think while you talk. You go ahead.
so I was going to say that the exposed group has a 2.5 times higher risk of developing botulism than those who did not eat bologna, sorry.
Okay. But the association was not
Not
statistical.
statistically
So you
significant
want to
because of the p-value.
right. Right. So the risk of botulism was 2.5 times greater for persons who ate bologna compared to those who did not, but the association was not statistically significant. What about hot dog? What's the attack rate for the persons who ate hot dog?
So that is 1 also. So it would be the L1 over 2. So it would be 50%.
Correct. And for the attack rate for those who did not eat hot dog would be
And that would be 8 again
42%.
over 19.
That's 42%.
Yeah,
correct.
that's what I have, yeah.
And therefore, the relative risk of botulism for those who ate hot dog compared to those who did not eat hot dog would be what?
1.2. Well, 1.19.
Okay, 1.9.
No, 1.1,
1.2.
1.2 rounded.
Okay, and if I told you the p-value was 1.0, how would you?
Yeah, P is 1.0. So
It's higher. So this is also not statistically
very
significant,
significant.
even though persons who consumed hot dog are 1.2 times more at risk.
Okay, of getting botulism.
Botulism.
Okay. All right. What about matambre? Let's see. Let me ask someone I haven't heard. Deidre, Simone, or Sheena? Sheena, are you here? Denise?
So, hi. So it would be for the persons who ate, the attack rate would have been 81%, but or 82% if you round it up.
Okay,
So
for
that
that.
would be 9 over 9 plus 2, that one. If we were to calculate for those who did not eat, I don't think 0 could be divided by no. Oh, you can't divide numbers by 0, but you could divide something of the other. So that's 0.
So those who did not eat, it's 0% because
Right.
0 over 10. And what about the relative risk?
So the relative risk would it be 0? It would be the attack rate over yeah, so it would be dividing the two attack rates, which would make that 0%, correct?
Well, you started off with the right statement. You can't divide
Oh,
82 by 0, right?
So you can't,
So
okay.
we'd say it's undefined.
It's undefined, okay.
Everybody agrees?
Yeah.
Well, I had 0, but I agree I guess undefined, right? Because I just put 0, but yes, that makes sense. Undefined.
Right. And the p-value was 0.0002. So there was a high attack rate for those who ate matambre. And a 0% attack rate for those who did not eat matambre. And the p-value, although we couldn't calculate the relative risk, was 0.0002. So what will they say? We'll just say that there appears to be an association of increased botulism among people who ate matambre, right? So even though we can't calculate the relative risk because of, mathematically, you can't divide zero, just looking at the attack rates among those who ate matambre and those who did not eat matambre, then, there appears to be an increased risk among those who ate matambre. Agreed?
So by that statement, then that since our RR is undefined, could we say then, I guess theoretically then, since our RR is undefined and not necessarily zero, then mm, and this, as we're saying it's significant, so
There
there's
appears
like
to be an association.
right.
So don't get hung up on the fact that we can't calculate a relative risk. We essentially said that 82% of the people who ate matambre got botulism, and none of those who didn't eat it didn't get botulism. Right? That's what this tells us. So even though we weren't able to calculate a relative risk, it looks like there is an important difference. And when we calculate the p-value, it was significant.
Okay, understand.
What about mate? I'm not sure how to pronounce this. Mate. Someone else, Vanetta, Christine, Keisha.
Can I try, miss?
Sure.
Okay, so for the attack rate, I have 4 out of 8, which is 50%.
Correct.
For those that ate, not eat, 5 out of 8, which is 62.5%. So the relative risk worked out to be 50 over 62.5, which is 0.8.
Okay. And the p-value was 1.0. How would you interpret your relative risk of 0.8 for mate?
So it was to be significant. So it would be but
1.0. So we say it's significant if the p-value is
no, if this p-value is less than 0.05, it's significant, right? So it would not be significant then.
right. But you should still comment on the relative risk of 0.8.
Okay. So the risk of botulism would be 20% less in persons who ate mate than those who did not eat it.
Right. But the association was not statistically significant.
Right.
That's the correct answer. Good. What about process
Wait,
time?
sorry, repeat that last part that you said.
Please.
Okay, so she said there was a 20% reduction in risk of botulism for persons who ate mate compared to those who did not eat mate, but the association was not
Not statistically
statistically
significant.
significant. Right, so that is the whole answer that you should give. All right, what about process time? Okay, anybody? I'm opening the floor in the interest of time.
So it's for those who ate, it's 2/3, which gives you 66.7%.
Wait,
Those
back up
It's 2/5.
5.
sorry, 5,
5,
Correct.
40%.
which is 40%, correct.
Correct.
And then those who did not eat would be 7/16.
16. 43.8. Yeah.
Okay, so the relative risk is
0.91.
0.9. And if the p-value was 1, then your interpretation would be?
Not statistically significant.
Well, remember I said the whole and
Oh, the relative risk.
So you're going to say there's a what percent reduction in relative risk?
There's a 10% reduction in relative risk of botulism in those who ate processed ham compared to those who didn't eat processed ham, but the association was not significant.
Right. Okay. What about sauce? Anybody?
The attack
I'm doing it now
rate.
because I didn't reach that far.
Yeah. Yeah, same. It says the attack.
78%. So
Okay.
7/9
Yeah, 7 and
for
9, yeah.
persons who ate it, and then 2/12 for persons who did not, which
Okay.
is 16.7.
All right. 17%. So your relative risk is
I get 4.67, 4.7.
okay. So if you look at it, 78 versus 17% looks like a big difference, just like the Matambri. In this case, the p-value was 0.009. So interpret that result for me. Anybody? Anybody? 4.6 p-value 0.009.
So the relative risk, the persons who ate the sauce are 4 times likely to have had the illness, and it is statistically significant because the p-value is less than 0.05.
Right. So persons who ate sauce are 4.6 or almost 5 times at risk of botulism compared to those who don't forget the compared to those who did not eat the sauce. And the result was the association was statistically significant. So we have a significant association between sauce and Matambri with botulism. What about salami? And if you look at the percentages, you see the big differences, right? What about salami?
That's one person. That's 1/2. That's 50%. As in the attack rate 50%, sorry. And then for the did not, so that's 8/19.
19, so that's 42%.
So that's 42. Yeah, got that 42%. So RR equal exposed 1.19.
Okay, or 1.2. And so that's similar to hot dog, and the p-value was 1.0.
So even though persons who consume salami are 1.2 times I don't know if this is grammatical or what. More 1.2 times at risk compared to persons who did not consume it. There is no statistically significant relationship.
So the risk of getting botulism for those who ate salami was 1.2 times the risk
Higher.
of botulism for those who did not eat salami, but it was not statistically significant.
Thank you for wording it for me, Doc.
What about, what's this solid ham?
So
Just
this
think of
is
the,
40% for
okay,
persons who eat solid ham.
2/5. And for those who did not eat solid ham,
That's 43%.
43.2. Yeah, 43. Yeah.
okay,
7/16. 40.8.
7/16. So the relative risk was
0.91.
okay, and the p-value was 1. You see the attack rates look similar in both groups. So how do we interpret it? P-value 1 and relative risk 0.9.
It was not statistically significant.
Okay, but in your answer in your test, you're going to say that it was a 10%.
10%.
Decreasing
Less.
botulism for persons who ate solid ham compared to those who did not eat. So we have two that are significant, sauce and matambre.
Matambre.
Right, so 82% of those eating matambre became ill, and none who did not eat matambre became ill. Almost all the persons who ate sauce became ill as well, 78%. However, 2 ill persons did not eat the sauce. So the question is whether both the matambre and the sauce were contaminated with botulinum toxin, or if they cross-contaminated each other, or if only one of the items was contaminated, but both were routinely served together.
I was just about to say, because the description at the bottom says it's I figure with a roll you probably serve a sauce. So probably.
Okay, so as it turns out, the sauce was not contaminated, but just served routinely with the implicated matambre. All right, so it's now 8:53. I think we'll end there. You can, look at the rest of it, and tomorrow we'll try and finish up this interesting case, and you can see how, as I said, it's an actual case that occurred in Argentina, but it's a good exercise in the process of case investigation. So we'll wrap up for now, and then tomorrow I see I'm switching classes, so I will do the 2 to 4 session and we'll finish up this case. Okay?
Okay, then.
Sorry, confirm. We have a 2 to 4 session. Is this the makeup for the TB course, or is this a different class?
No, I was to have the 4:30 to 6:30 class tomorrow, but I switched with I'm not sure who was doing your 2 to 4 class, but I will continue this case investigation, and then the class that would have been 2 to 4 will be at 4:30.
Okay, duly noted. Thank you. Are we going to have the TB class, or are they just going to share the slides for that one?
I think we'll have to share the slides. Unfortunately, Dr. Baker has had a family emergency. So unless I'm not sure she's back in the island. So, but it means we'll probably won't cover it for the quiz, the final quiz.
Dr. Duncan, will the final quiz also be online or it will be in person?
Let me get back to you on that. I'll let you know before the end of the week. We have persons overseas, right? We have 2 persons in St. Lucia, was it? Or is everybody in Jamaica?
I know we have one member in St. Vincent. I'm not sure if she's doing this course. I think it was Cindy, but I know she's in St. Vincent, I think.
Okay. All right. We may have to do it online, but I'll get back to you before the end of the week.
Did we
Okay,
get a breakdown of the structure of the exam? But this one will be short. The like case studies and short answer questions.
Multiple choice and short answers.
Okay, noted. Thank you.
All right. So tomorrow at 2.
Okay, Doc. Thank you. Good night.
thank you. Good night.
Good night.
Good night. Good night, everyone.
Right, Doc. Thanks.